Welcome everyone to this month's CMR Journal Club. My name is Nicole Seiberlich, and I will be from now on co-moderating together with Matthias Friedrich. So this week I'm on the hook. Just as a brief introduction, I am an associate professor at the University of Michigan, and I do a lot of work in cardiac MR, and so I'm really delighted to be here and to be hearing about all of these great papers. So for this month, we've chosen to focus on diffusion tensor cardiac MR. So we have a couple of great papers in that topic. And in particular, we're going to look at some of the new possibilities for rapid breath hold DTI in cardiac MR and also free breathing mapping. So with that, I think we can get started. So our first paper is going to be presented by Dr. Pedro Ferreira, and this paper is entitled Accelerating Cardiac Diffusion Tensor Imaging with a UNet-based Model Towards Single Breath Hold. So at this point, I'm going to stop sharing and let Dr. Ferreira take over and introduce the paper. And as usual, if you have any questions, you can drop them in the chat. I'm happy to answer them. And as we're done looking at this article, you can also ask questions yourself, just verbally, if you'd like.
Well, thank you for the invitation. I hope you can see my paper now.
Yep, it's perfect.
Great. So so this work from the Brompton was about trying to make CDTI a bit more clinically viable. If you're not familiar with in vivo cardiac diffusion tensor imaging, which I'm going to call it CDTI from now on, it's basically a new technique, in particular the in vivo part of it, to characterize the microstructure of the myocardium. Because it's in vivo, we can do it in the living heart. That makes it much easier to access and probe the microstructure in different cardiac diseases. It also allows us to look at microstructure dynamics because we can image both in systole and diastole, for example. But it's extremely challenging at the moment. And in diffusion tensor imaging, you basically calculate a diffusion tensor for each voxel of your image. And you can then extract multiple parameters from the tensor. For example, you can look at tensor shape, tensor size, or tensor orientation, for example. And tensor orientation has been really promising because it allows us to probe the orientation of the cardiomyocytes, and in particular, their helical structure and also the fact that they are bundled in sort of in a laminar arrangement that we called the sheetlet structure. It has other names. Some other groups call it myocyte aggregates, but basically this structure is very important for cardiac function because it's sort of the mediator of what enables the heart to contract so significantly. So you have this wall thickening of approximately 40% during systole, and that's because of this laminar arrangement of the cardiomyocytes. And we can probe this, of course, with a coarse spatial resolution, but we can probe it with in vivo CDTI. However, there's a lot of challenges to translate this to the clinical routine. One of them is that it takes a really long time at the moment to acquire our data. Diffusion is encoded by signal loss, so inherently is going to be a low SNR technique. And this is really the case for in vivo. It's a very low SNR. And so we need to basically acquire multiple repetitions of the same acquisition over and over again to build up our signal. And in our research protocol, we approximately acquire 12 breath holds worth of data to get one slice at one single time point in the cardiac cycle. So this is quite slow. We typically acquire just one slice because of this in two cardiac phases, in systole and diastole. That's what we most commonly do. So, but that's 24 breath holds. And this is just not viable at the moment to translate to clinic. So there's been a lot of AI approaches to try and basically solve this problem. the most obvious one is to use AI to denoise the diffusion weighted images. But there's been also some interesting work showing that maybe we can use convolutional neural networks to aid on that denoising, but also use it to calculate either, for example, tensor parameter map. So that's what Aliota did previous to this study. He basically went straight from a subset of diffusion weighted images all the way to the final results by using a U-Net. And this work is similar to that, but the previous work had some limitations. You have to train a convolutional network for each tensor parameter map, and he managed to get good results with either with calculating fractional anisotropy and mean diffusivity. In this work, we thought, why not go a step back and actually use a convolutional neural network to calculate the tensor. If we calculate the tensor parameters, then we can extract any result from that, and we're not limited to just the ones we trained our data. So that's the approach of this paper. And so I can go now, I guess, to figure one to show sort of the idea behind this paper. So typically, we acquire a lot of data, and then we do a linear least square tensor fit to get our tensors. And what we did here was to use a U-Net convolutional neural network to get to the same tensors, but with a reduced data set. So it was trained to do two things: to calculate the tensor, but in a denoised way. So that's the approach of this paper. The training and testing data sets, they were all acquired with Siemens Skyra 3T scanners, and then more recently with VIDA 3 Tesla scanners. So they're both from the same manufacturer. This is one of the limitations. And the protocol was identical for all of our data sets, basically a STEAM API acquisition. So in total, we had 744 data sets. A quarter is healthy volunteers, and the rest is clinical data, which is described in this table. So we have quite a lot of different cardiac diseases, several different cardiomyopathies. Also, we have a large data sets with MI, chronic MI data that we also added here. So clinical data is approximately 75% of all the training data that we used. And for this data, when it was originally acquired, the mean number of repetitions, as I mentioned, was 12 plus or minus 2. And we tend to be a bit overdo it in the number of repetitions, because if the scan is a bit more difficult, then we can actually remove some of the most difficult and most corrupted data sets that we get. So you don't need to acquire so much data, but you still need to acquire quite a significant amount of breath-holds to get any good quality data. And so originally we calculated using all the data, we calculated our diffusion tensor results. And then we moved on to the AI part of the work. We basically created 3 different subsets of data. One that could be acquired in 5 breath-holds, one in 3, and then the most extreme one, just 1 breath-hold worth of data. And we trained the U-Net to basically try and get to the same tensor results. To compare with the conventional way of calculating the tensor, we also used these subsets, and we calculated the tensor with a conventional linear least square fit that we use. We used 70% of the data for training, and then 15% for validation, and then finally 15% for testing. To do this work, we just used a beefed up desktop PC, nothing very fancy. The U-Net that we used is a fairly off-the-shelf one. We just added some batch normalization layers because this really helps with to prevent overfitting. And then to get our final results, we just used the MATLAB-based software we developed in-house to get all our data. And so for each data set, we basically have 7 sets of results. We have the original results with all the data. We then have 3 sets where we used AI to calculate the results, and that's for the 5, the 3, and the 1 breath-hold. And then we repeated this all subsets also with a conventional way of calculating the tensor. So please feel free to interrupt me if this is very confusing, but that's sort of the methodology that we used. So here's an example of our results for a healthy volunteer. So this is our reference tensor results. So this is fractional isotropy, mean diffusivity, helix angle, and E2A, which is the sheetlet angle. So this is the four parameters we normally look at. And this is using all the data sets. And then this is the conventional way of calculating the tensor with a linear least square, but only using 5 Bretels worth of data, 3 and 1. And the data is not too bad for 5 Bretels because this is a healthy subject. The data is of good quality. Clinically, quite often you have more challenging scans, so we might get slightly even worse results when using only 5 Bretel worth of data. But for this particular example, it looks not too bad. And then as we move on to less and less data, 3 Bretels and just 1 Bretel, it gets extremely noisy. Most of the results still look similar. I would say some of the most details of the data, for example, we normally, at least in a healthy heart, we see a higher fractional anisotropy in the mesocardium, so in the middle of the myocardium. And we can still see this structure with 5 Bretels worth of data. For 3 and 1 Bretel, then we kind of lose those details. Now this is exactly the same subject with the same results, but now comparing the reference scan with the UNet predictions. And we can see that the UNet introduces a lot of smoothing, which is very typical for when using UNet to generate images. But I would say that for 5 Bretels worth of data, I don't really see a big improvement from the normal way of calculating the tensor. But then we start to see, I think, even though it looks very smooth, I think this data looks better than the one with you calculated with the conventional way of doing a linear least square fit. So this is one example, but if we now compare the errors compared to the reference scan for all subjects in the test data set, so this is healthy and patients, we can basically see exactly what we saw for that example. At 5 Bretel worth of data, we don't have a lot of differences between the linear least square and the UNet, but as we decrease the number of Bretels, the errors are significantly lower for the UNet. So this is sort of the main result of this paper. So for all tensor parameter maps that we normally look at, when using 3 or 1 Bretel worth of data, we get better results when using convolutional neural networks instead of just analytically calculating our tensor. Now, one of the things we were slightly afraid of is because we're generating images with the UNet, are we hiding a real disease? Are we just training the UNet to create an average heart, that sort of stuff? So we looked in more detail in the chronic MI data that we have. So we have a few subjects on the test data set with chronic MI, and we know from many previous publications that when looking at mean diffusivity, we have higher values in the infarcted region because we have edema, and so diffusivity tends to be higher in this region, and that's exactly what we show in this particular patient. We have an infarct in the inferior region, and so we have much higher diffusivity compared to the remote regions of the myocardium. When calculating with only 5 Bretels worth of data, the conventional way, we still see the infarcted region, but then we kind of start to be a bit more difficult to identify the infarcted region. With the UNet, even though the data is more smoothened, I would argue that even with just 1 Bretel worth of data, we still see some differences, but the contrast is definitely reduced. But overall, I would say that for the most extreme 1 Bretel case, I would rather see the UNet results than the linear least square fit. So prospectively, after the first round of reviews, we were asked to test. So most of the training data that we have is collected in the mid ventricle. And one of the questions I had from the reviewers was, can we use this in the basal and apical regions of the ventricle? And so for that, we prospectively acquired in 5 healthy volunteers 5 slices covering from base to apex, and we used the UNet results to see what happens. And basically, we get the same results, 5 breath holds worth of data. We don't see a lot of difference. In fact, the linear least square is slightly better. But when we reduce the amount of data acquired, we get much better results with the UNet. But we do see higher errors for the blue and green dots, which is basically the most basal and the most apical slice. So this is not surprising. We don't have training data in these regions or we don't have a lot of training data in these regions of the ventricle. So it's not that surprising, and it's basically showing us that ideally we should have more training data for these regions, but still we could see that we could use the UNet when having a very limited amount of data. So that's the main results of the paper. So as a summary, if we're using for reduced data sets that can be acquired in 3 or just 1 breath hold, the UNet results outperform the conventional way of calculating the tensor. The UNet was originally developed to do semantic segmentation in biology images, but it has been used before for image generation, in particular for parallel imaging problems. And here we show that it can also be used to derive diffusion tensors from diffusion weighted images. The UNet has some skip connections in this architecture that allows us to keep some of the details, some of the high spatial resolution detail, but still, nevertheless, there was a lot of smoothing of our results, which is an expected thing when using UNet-like architectures. I have here something in green that I'll come back in the end. But one of the questions you might have...
sorry, Dr. Ferrer, I'm just going to ask you
yes.
to wrap up so we have time for a quick question before we move on to our next paper.
All right, so I'll just very quickly, you might be wondering, why do we want to train AI to analytically calculate something that we can do it analytically? And I think my argument for that and why I did this work is convolutional neural networks are capable of actually detecting spatial patterns, while an analytical solution is voxel to voxel, and it really ignores spatial patterns in neighboring voxels. So of course, if we have the analytical solution and we have a really good data set with lots of input data, then of course it makes sense to use that instead of AI. But for extreme cases, and as we're showing here, AI potentially can give you better results. So yeah, so I'm wrapping up as I don't have any time left, I guess.
Great, thank you so much for that extremely rapid presentation of this great paper. Are there any questions from our audience? I'm looking at the chat and I don't see anything, but if anybody has one, they can go ahead and unmute themselves and ask. Right, maybe I will ask a quick question just to get the ball rolling. So, you say you used a reduced data set for the 5 breath holds, the 3 breath hold and the 1 breath hold. Have you, and for that you collected fewer averages, is that correct?
Yes.
Got it. So have you thought about collecting maybe data in a different way, undersampling it, or thinking about other ways that maybe you could generate noisier data sets, but more data for use in the actual reconstruction?
Well, we have PhD students working on all sorts of AI applications. Some of them are using compressed sensing techniques. I'm not sure if that can be also applied here. That will not really reduce your number of breath holds, but it will shorten the API readout, I guess. So that's kind of slightly different from what we're doing here. But no, we just randomly picked up diffusion weighted images. Yeah, so but not playing with any sort of undersampling.
All right, thank you. Are there any other questions? Right. In this case, I think in the interest of time, we'll move over to our second paper. This paper will be presented by Dr. Yanji Zhu, who is joining us from China in the middle of the night, so we really appreciate that. And this paper is entitled Slice-Specific Tracking for Free Breathing Diffusion Tensor Cardiac MRI. So I'm going to ask Dr. Zhu to go ahead and take it away. Perfect. We can see everything already. Oh, don't forget to unmute, though.
Okay. Can you hear me?
Yep, perfect.
Okay. So as since diffusion imaging has been widely used in the brain and in neuroimage, and also it can be used in cardiac imaging as a non-invasive technique to characterize the myocardial microstructures. And I think its advantages has been introduced by our previous speakers. So I will not repeat this. So one major drawback of cardiac BKI is a very long acquisition time. Since we need to acquire multiply diffusion directions and multiply repetitions, so the acquisition time is very long. So there are several methods and also since respiratory motion often result in misalignment along the myocardial regions in the acquired images. So we need to use some motion correction methods to reduce these motions. And several methods in our previous studies has been proposed. The first one and this most used one is breath holding, and the second is the navigator gated with a fixed tracking factors, and also is slash tracking methods. However, the breath holding is I think is a very useful method, but since breath holds makes the patient very discomfort and prolonging the scan time, and the navigator gating methods and the efficiency with a very low efficiency is about 13%. And the slash tracking method use a fixed tracking factor is mostly in 0.6. And the inaccurate tracking will always induce the misalignment of the BPI images. So there are several methods has been proposed to improve the accuracy of the tracking factors, such as Procol and FastNavi methods. However, these two methods always treat the whole heart as a rigid object and using a fixed method for each individual. So they do not account for the differences among the slices. So in our studies, we aim to develop specific tracking methods, thus to calculate a specific tracking factor for each slices. And we calculate the tracking factor in two directions, in the heartbeat direction and the right-left directions for each slice. So here we can show the main framework of our method. Here is the framework. First one, we need to acquire a group of coronary images. And in these images, we can calculate the displacement of heart using the registration method. And also along these acquisitions, we acquire the diagram navigator signals. And we calculate the respiratory motions in the head-foot directions using these navigator signals. So, so here we can extract these respiratory curves from these signals. And for the coronary images, we made the non-rigid registrations to a reference images, and then we can project the sex slices to be imaged in the coronary images. And then we draw the we manually draw the epicardial contours, and then we can see the shapes image locations within these heart regions, and then we can calculate the motion fields in the two directions as the displacement of the heart. Then we can extract two curves to indicate the heart displacement in the heartbeat direction and left-right directions. So using these two directions, then we can project it to the patient coordinates and calculate the coefficient to with this with this respiratory displacement calculated from the navigator signals. So here is the formulas to transform our heart displacement to the patient coordinates. And here is the formula to calculate the slope and between the respiratory motion and slash displacement. Then after calculating the tracking factors, and we can update the slash locations in real time during the DTI acquisition. So for the acquisition, we also need to acquire the navigator signals and then calculated the multiply the tracking factors to calculate the directions in HF and the RL direction, and then we transform it back to the imaging coordinate system and to update the slash locations. So here is the whole methods. And then we can see our results. We perform the experiments in the 17 health objects and on a 3D scanner of United Imaging Healthcare. And then at first we acquire 16 coronary images and we acquire 4 SHACS images for each volunteers. And at the beginning, we acquire about 6 DWI images to determine the best trigger delay times for each volunteers. And for each device, we acquired every 2-hour intervals to ensure the sufficient SNRs. So we compared with 2 other methods. The first one is multi-breath holds, and we use as a reference. And the second one is tracking with specific tracking factors of 0.6 and fixed tracking factors of 0.6. And the third one is our own methods using a specific tracking factor. So we can see the results. So here is here the figure 2D shows the extracted curves of navigators is indicated with the blue line, and the orange line shows the heart displacement in the heart foot directions, and the green line shows the displacement of the heart in the left-right directions. And we calculated the linear coefficient of the displacement of navigators and with the heart displacement in these 2 directions. And the table 2 listed all the coefficient/specific tracking factors in for the 4 slashes, and we can see that the respiratory induced displacement is always generally smaller at the basal and larger at apex. And to tell the truth, we think the tracking factor in the apex is not that accurate as in the basal and the middle slashes, since in the images, the basal slash covers very few areas, and so the tracking factor, I think, is not that accurate as other slides. And here is the acquired DWI images using the fixed tracking factors and our methods. And using specific tracking, we can see that the image is aligned well. And using a fixed tracking factors, that some images are misaligned with others. And here we also use ventricular lines in the DW line, in a DW image, and see that using a slash-based tracking and other all DWIs aligned is better than using a fixed tracking factor. And here we also compare the obtained DWI parameters calculated using different methods. Here we use the breast holes as a reference. And we can see that if we use a fixed tracking factor, the obtained DWI parameters is a little different from the breast holes, but using a slice-specific trackings are more close to the breast holes results. And also we use a pair t-test, a sample pair t-test, and we found that use a slice-specific trackings is close to the breast holes. Here are some figures, DTI parameters, that we can see that using from subject 2 and subject 4, we can see that using a fixed tracking factor of 0.6, sometimes the HA parameters is not that good as we predicted, and using a specific trackings, the HA images is improved. I need to mention that here, this table here should be 0.2. Yes, here is a table error. We have already mailed to the editors to correct it. And here is an example from subject 4, and we can see that also the using a specific tracking improves the image qualities. Here is the 3 slices from 1 volunteers, and we can see that for the 3 slices, we improve the image quality than the than the fixed tracking factor. So, okay, here is the main results. And in the discussion, we think that when we do the comparison, we try to minimize the some factors that will interfering the results, such as we need to keep the breast holding that at the same intervals, and otherwise, if the interval is too long, the recovery of the longitudinal magnetization will make the first image is too bright and affect the results. And the other one is we can use a slice interleaved acquisition to acquire more slices and enlarge the coverage of the heart. And since now we always, for most of the time, we acquire only 1 slices for 1 patient. Okay, I think this is my main results of my paper. Thank you.
Great, thank you so much, Dr. Zhu. Are there any questions from the attendees?
I can ask a question.
Yeah.
So you've done slice tracking, but you still apply a non-rigid registration to the diffusion weighted images?
Yes. Since
okay. My question is, so each diffusion weighted image, you have a diffusion encoding in a certain direction. Do you correct this for the non-rigid deformation, or is that not an issue? I have no idea. I'm just wondering.
I mean, using a slice-based tracking used to acquire the image at the same location of the heart, but using the image registration corrects the non-rigid deformation in the implant motion. Yes, I think this is the correction methods from 2 different ways. Yes.
And will that affect the diffusion encoding direction in each pixel of your diffusion weighted image, or is not really an issue?
I don't think this is an issue. Yes.
Okay.
Thank you.
Any other questions out there? I do have a really fast one though. So for your slice specific tracking method, how much faster was your acquisition, or was it just that it was free breathing and that's why it was useful? Like when you compared kind of the times between the breath held acquisition and the free breathing acquisition?
We don't calculate the exact time since for breath holding, the patient need to rest at some time. Since for multi-breath hold is not very comfort, but in free breathing, it can acquire the images continuous. And so we acquire image every 2 heart per DWI image. Yes. So for one, so about if we acquire 10 directions, I think is about 20 seconds or a heartbeat.
Got it. So it's faster and more comfortable for the patient. Is that correct?
Yes.
Okay.
Yeah.
Okay. That was my question. So if there are no other questions, I'm going to hand over to Matthias to present the Journal Club for the next month.
Yeah, thank you. So next, and I'll share the screen. I hope you can see that. Next month, we will have a focus on myocardial edema. I find this always interesting because you not only learn about the methodology, but also about the physiology of acute heart disease. And these 2 papers will address one disease. It's preeclampsia, or a clinical syndrome where myocardial edema seems to play a role. And then also an interesting paper in athletes before and after a race, whether there is myocardial edema. And then we will discuss, hopefully, what that all means and how it relates to stress-induced cardiomyopathy and heart failure. So I hope you can join next month. Thank you, Nicole.
Great. Thanks, everybody. See you in a month, we hope.
Bye.
Bye.